So Hannah, this is my friend Todd.
Hi, Todd.
This
Hey,
is my friend
Hannah. How are
Hannah.
you?
I'm okay. I'm okay. Your name came up because I was recently at my OBGYN and no, at my primary, and they were suggesting that I get genetic screening.
Oh,
So I
awesome.
went to my OBGYN to do it, and they said just a hint is if you haven't gotten life insurance already, that your results from your genetic screening can change it. And so what it did is put me in this limbo of not knowing whether to do it or not. And
Right.
so Dr. Edric Karen said, let's talk about it. I know just
Hmm.
the person.
That's
Hmm.
right. Absolutely.
And Hannah, do you want to say what your background is? Why they were saying that?
Yeah.
Yeah. So my mother has had breast cancer, and I've got enough smatterings of cancer around in my family history. My paternal grandmother had breast cancer as well,
Okay.
and my maternal aunt had, I think it was breast cancer that spread to lung.
Hmm.
Okay. So multiple breast cancers, same
Yeah.
side of the family.
Yeah.
Wow. Excellent. Yeah. So you're similar to me. Before I went through training with my first lab, which was it's about 7 years ago, I had really no idea that any of this existed. It was quite the eye opener. And like you, definitely have cancer on my mom's side of the family, not so much on my dad's side of the family. And in fact, my mother survived breast cancer. She's now 73, was diagnosed at 49. Um,
Wow.
and interestingly enough, or maybe not so interestingly enough, um, yeah, I was the first individual to talk to her about hereditary cancer risk assessment and the opportunity to get tested and, put genetic insights into play with her cancer risk. And quite frankly, what I sold her on ultimately as her youngest son was not her personal risk for cancers because she had already beat it once and she was getting older in age. It was moreover family risk. So the thought that potentially she could be carrying a broken gene that's autosomal dominant, meaning there's a 50% chance that her children inherited that gene directly from her. And beyond that, to be completely honest with you, and this is pretty funny, she wasn't so concerned about my risk, but it was her four granddaughters that she was
Hmm.
really concerned about.
Mm-hmm. Mm-hmm.
Absolutely. So similar backgrounds.
Okay. All right. So you said though that this was your kind of start into it even before you got more into it. So can you walk us forward to your role today?
Yeah, yeah. So I've been representing or helping to get the word out there about hereditary cancer testing and risk assessment for roughly 8 years. I've worked for two different laboratories. I've learned a ton in my adventure into hereditary cancer and exclusively marketing this for the last 8 years. You know, when I first started, I really didn't know much about this. Went through an extensive training program with the pioneer in this space, learned a ton, and really self-identified my personal risk. Guidelines today are ever expanding, appropriately so, as we understand more about hereditary gene mutations and their impact to cancer risk. Um,
Mhm.
and we explore different types of histories. Really, the biggest opportunity in this market right now is the unaffected patient. So, a patient that Dr. Ojo might be treating, like you and I, had never had cancer, but have cancer family history that really would substantiate a high risk kind of profile,
Mhm.
like a young breast cancer.
Mhm.
Just in my family, really the only cancer that qualified me and my mom for hereditary cancer testing was that young breast cancer diagnosed at age 49. So believe it or not, with just one cancer in the family, out 2 degrees, so as far out as grandparents,
Mhm.
diagnosed young at breast cancer qualifies you. You meet strong guidelines. And in all likelihood, if you have commercial insurance or federal insurance, you're not going to pay a penny for your testing. So it's very, very, very well covered, specific to commercial insurance. So when it comes to the different societies that weigh in on this, the USPSTF, which is really the U.S. Preventative Services Task Force, along with the Affordable Care Act, really combined effort mandates that commercial payers, when you meet coverage for this type of testing, there is no cost sharing to the patient.
Mm-hmm.
So that's probably one of the biggest ahas for patients. And quite frankly, in many cases, a big aha for clinical providers that are newer to this opportunity. So my mother, when she was tested, she did not pay a penny for her test. Why? She met strong societal guidance. Likewise, myself did not pay a penny. It was fully covered by insurance because of my mother's cancer family history. Does that make sense?
Mm-hmm.
Yes, but I want to ask a question because I was offered to do it either in office at my OBGYN and they seemed to be kind of recommending that I go with a company that specialized in that, which meant a different appointment, new location, all that kind of stuff.
Right.
So can you walk me through that a little bit?
Yeah, so specifically your question is?
Specifically, what's the benefits of why go to a different place than just the office that I'm already in? What are the pros and cons of going either way, I guess?
Yeah, so that's a good question. Medical evidence supports that the best time to offer testing is the time that you're identifying that patient's at high risk. So let's say your doctor asked you a series of questions about your cancer family history, or moreover, you filled out a written questionnaire. From that exercise, he or she really identified you at high risk based on your history. There's a very prominent study that took place in community OBGYN that supports the best time to offer testing and get a patient tested is when they screen high risk.
Mm-hmm.
The challenge we run into in this space is really no different than in most opportunities. Once the patient leaves the appointment, goes back into their busy whirlwind, a lot of times, life takes over and we forget about that opportunity.
Mm-hmm.
And referral to genetic counseling is an awesome opportunity, but the catch there is patients have to be very motivated, and potentially in some cases are waiting. It depends on, the locality, but a month to 2 months
Mm-hmm.
to get in on that appointment. The reality is most genetic counselors are perfectly okay with providers like Dr. Ojo and others that are in OBGYN and primary care, with testing appropriate patients and then referring those patients once they come back positive or high risk negative to the genetic counselor, to have that type of additional education to understand what those results mean, and quite frankly, have the best outcome possible with those genetic insights.
Okay.
So it really depends. Every practice is different. There's no, written rule, like many things, where a doctor has to have this protocol in order to have, this desired outcome. So it sounds like your provider was more in line with, we will screen you with a questionnaire or a series of questions. If you're high risk, we would love to set you up with an additional appointment to consider testing. In some cases, that's outside of the office. So that's with a board certified genetic counselor. In our locale, they're typically situated in cancer clinics, or potentially there's someone on that staff, if it's a large OBGYN clinic, that specializes in hereditary cancer risk assessment and testing. So more or less an internal referral to a partner provider. Does that make sense?
Mm-hmm.
So in your case, what was it, an internal referral, or was it more a referral outside of the clinic?
Outside.
Okay. Was it to genetic counseling?
Mm-hmm.
Okay, excellent. Which is a great model. What we found is there tends to be, like any referral pattern, there's always a dropout rate, right?
Mm-hmm.
And I'm in that. I have not made an appointment. I've done nothing. I did exactly what you said. Life swept me away. It was like a moment where I had to choose to do one hard thing or another hard thing,
Right.
Which brings me to the point of, like, who wants to find out? Obviously, I understand. I hopefully am a semi-intelligent person who can understand that if I find these results, I'm more in control of being able to do preventative measures. But it's not like a real appetizing thing for anybody to want to go do.
No, it's not the most uplifting conversation to talk about your cancer risk. But I think the reality is, and this is where I think, we lose some patients, is they don't understand, by knowing your cancer risk, your provider and you can take the reins on your specific risk and manage it appropriately.
Mhm.
And in the case of hereditary cancers, while they are rare, right, only 10% of those tested will come back positive for a gene mutation that impacts cancer risk. That's still pretty significant when you factor in the increase in risk when you are a mutation carrier. So we could pick on BRCA1. And what we know about BRCA1, one of the most common mutations out there in terms of knowledge and studies, 87% breast cancer risk, lifetime risk, when you're BRCA1 positive, 63% lifetime risk for ovarian cancer. So
Wow.
those
And
are scary numbers that if you're
right.
not tested, you would have no idea.
Mhm.
And therefore, one of probably my most passionate doctors in the territory I've been working with for my entire 7 years in the space, the way she spends it is, while I'm a great doctor and you trust me, I can't look at you with genetic X-ray vision and tell whether or not you're a mutation carrier.
Mhm.
So what I offer is this simple blood test that is very well covered by your commercial insurance. You likely, based on your history, you meet strong guidelines. You likely will pay nothing for your test. Fortunately, the lab we've partnered with has a patient pay price of $249, which is also subject to financial assistance.
Mm.
So you can see where I would say, and Dr. Ojo would love your weigh in on this, but the two major barriers in this space to creating greater access to this type of wonderful testing historically has been cost.
Mhm.
And if I was a busy doctor in an ever-changing space, and I had a few bad experiences where I recommended testing based on guidelines for a patient, and lo and behold, their insurance wouldn't cover it. Now a patient's saddled with a large bill. If the lab does not have a patient pay price, there's only a certain number of those experiences that provider is going to be willing to take on, to where they're going to say, maybe it's best that I refer this out. But then you have the challenge of referral, patterns and compliance, like you said. If you don't strike while the iron's hot, so to speak, and that topic is clear and concerning in the patient's eyes, what happens? You leave the office, you've got your referral slip, you go back into your busy whirlwind, you remember bits and pieces of that conversation. A year goes by, you go back to your OBGYN. Hopefully they inquire, which most will. Did you get that test result? I don't have a result in your chart. And we start all over again. The challenge with that is we've lost an entire year, potentially. I say that, and I'll speak out of the other side of my mouth. Some patients just need time, right? You need time. Maybe there needs to be some additional concerning history with a close relative that comes down with another cancer. I know Dr. Ojo, from clinical conversations we've had in the past, has had that situation where the first time we discuss this, the patient says, I'll think about it. Then a year goes by or 6 months goes by, and another concerning cancer pops up in the family tree. And it's amazing. It's like a light bulb goes off, almost like my mother, when I finally connected the dots on, did you know your cancer risk could actually impact your grandchildren? And it was like this aha moment. And if you don't strike in that aha moment, a lot of times you lose, you lose the patient's interest, because we're all very busy.
Yeah.
And we don't have a lot of emphasis on preventative medicine in our culture. So,
Well, yeah.
It's true. Very true.
And it's not necessarily the norm for all offices to have this type of testing available in the office. And for that reason that you said, Todd, which is just cost, and also which lab you're partnering with. And I would definitely agree. Cost has been a big inhibiting factor. That's why it's really great to be able to have a lab in which that part's really cognizant for their, on the patient's end. But the tests are simple, it's a simple blood draw or a simple saliva specimen, which is easy enough. And you're right, the time to capture is in that moment when you're thinking about it and when you're talking about it. And even though for Hannah, just to refer back to what you were talking about at the beginning, the office said to think about your life insurance policy before you move forward with a test. I would say, yeah, that makes sense. But the answer that you get, whether you are identified to have a mutation or you're a high risk negative or you're negative, period, you know, um, that value, I think, you can't put a number on it, for how that's going to affect you and then affect the generations after you, your family, your children, potential grandchildren, and such. So I think it's something that I'm glad that we're talking about it today, and I think it should be part of the main conversation when you're at the doctor's office, OBGYN, primary care, whatever. And it shouldn't just be based upon if you wrote something down on your medical history. Because sometimes things can be missed, when you actually sit and think about it, it's like, oh, yeah, this person had that, this person had that. It should be a part of the conversation, the normal conversation.
Well, in my case, also, some of those, that history is tied up in complicated emotional connection that I don't really, it's tough to have to bring this up, sometimes. So for me, then the diagnosis itself, which is helpful to me, that's the piece of history that my doctor needs. I'm like, well, it was either this or it was this, which is not actually helpful. But the aha for me is not only breast cancer, but ovarian, which seems harder to detect, that you would then do a different course of screening based on these results for something that might be really easily missed. And since we just talked about ovarian cancer a month or so ago, that's on my mind, is something to be aware of in advance.
Yeah, I mean, we're learning every day. I guess, and I should have mentioned this early on in the conversation, but what excites me the most about genetics is how young it is. Cancer as we know it today is a scary word in the dictionary, but I'm confident, and it was just 7 years experience in this space. And the not so distant future, cancer will not be a bad word in our society as we know it. Genetically, I feel confident that we will be able to turn it on, and more importantly, we can turn it off genetically. That is the direction we're moving, and it's pretty exciting to be a part of it. And all the while, with what we have today and what I've seen, with Dr. Ojo's help and partnership, is many, many, many lives saved. In my 7 years in this space, I can confidently say at least 300 lives saved through this type of testing. And it's still so underpenetrated. Statistics still support 80%, up to 80% of women that meet guidelines have never had a conversation about this with a professional. Huge opportunity. And looking at the individual syndromes, Lynch syndrome, which is more tied to colorectal, endometrial, and ovarian risk. 95% of individuals that have a mutated gene that constitutes they are Lynch syndrome positive are not aware they are. And a lot of it ties in with some of the challenges and the barriers of, this type of testing early on. And then, doctors that maybe tried it 8 or 9 years ago, 10 years ago, when guidelines weren't quite established and coverage was dismal. They had a bad experience, and, they're gun shy. And let's face it, doctors are no different in their environment than everyone else's environment. They're being asked to do more with less time, less money. So they have to be very strategic in their approach and what they're going to focus on to where they're going to get the best outcome for their patients. So I don't necessarily, I say that to say that I don't necessarily blame really anyone. It's just the evolution of this space. And what I can say today, in the lab that I work for today, really our number one goal is to provide quality genetic insights to more men and women that not only need them because they meet criteria and they're indicated for this type of testing, but they want these genetic insights. And that really is what gets me up out of bed early, Monday through Friday, is knowing that the education that I can bestow on others and the updates in this amazing space in healthcare, we can save more lives. We can continue to make a dent in that 80% of women that have never had this conversation, right? That's a miss. That's a big miss. And that's my job, right? I wear that on my sleeve every morning. I get out of the gates early. Why? Because we need to continue to raise awareness on this topic and continue to save more lives.
Yeah. Well said. It's part of the arsenal, you know, and it's a strong part of our arsenal in the fight against cancer. And again, you know, we're focusing on talking about breast cancer, ovarian cancer mostly, but Todd, just like you brought up colorectal cancer, pancreatic cancer, you know, and so it is part of the arsenal, and we need to utilize it more as physicians and as patients demand it more. So knowledge is power. I'm glad we're able to impart some of this on those that are watching today.
Yeah. And Todd, thank you. You said you get up. This is why you get up early. And he did get up early because we're recording this on a Monday morning, first thing. So we're going to air this in January. So we didn't do this live, which leads me to the point that if you are watching now and this has raised a bunch of questions for you, please drop them in the comments and then we can come back and answer your questions as they come up. Todd, do you want to be reached? Is there anything you want me to be able to put for people to get in touch with you?
I would love the opportunity. To me, you know, knowledge is power and specific knowledge is empowering. So when we have genetic insights and we understand our genetic insights, inevitably we can have better health outcomes. And that's what this is all about.
Great.
Thank you for doing what you do. Thank you for being passionate about it also. It's really infectious, and you feel that just in the conversation and just talking to you. I know there are a lot of women that will watch this today, and there will be more than those 300 saved. There'll be more.
You've made me non-compliant to compliant. I'll do it in the week.
I'm a phone call away, Hannah. Would love to talk to you more. Absolutely.
Cool. Well, thank you so much. And thank you, Dr. Ojo-Karens, for holding my feet to the fire.
Yeah.
Lovingly.